What are the mechanisms that are driving these outcome disparities we see due to poverty and childhood cancer? The short answer is we do not completely know yet. This is an active area of investigation. We have some hints from data that exist so far, and they probably, at this point in time, we think fall in two major categories. One of them likely does have to do to access to care, which you can think of probably in two different domains. So one of those would be the ability of a family to access chemotherapy medications and give those medications to their child in a timely fashion. And so an example of that is work that's been done by the Children's Oncology Group led by Dr. Smita Bhatia, which has demonstrated that non-adherence to oral chemotherapy, meaning that you don't take your oral chemotherapy medicines at least 94% of the time, is associated with a higher rate of relapse. And you can imagine for families struggling with poverty, which might mean things like not having enough food on the table or not being able to get transportation to the hospital, being able to be 94% adherent to your oral chemotherapy may be a challenge. So I think that's probably one large mechanism driving outcome disparities, although more work needs to be done there. We're currently investigating some other possibilities, which really don't have to do with the idea of adherence to oral chemotherapy medicines, some to do with access and some to do with biology. So a second access issue really would come down to a very basic need of transportation. And so, for example, when we treat children with chemotherapy, one of the things that we do as physicians is we suppress their immune systems. We make them be at risk of infection. And that can mean that if at 2 a.m. your child has a fever, we need them to be in the emergency department in less than an hour so we can have IV antibiotics in their body. And if you don't have a way to get to the hospital safely in an hour, might that potentially mean that your child ends up coming in sicker and going to the intensive care unit, for example, and might that impact on their outcomes? That's an open area of investigation. We're not completely sure if that's true, but it's something we're studying right now. And a third possibility beyond adherence, beyond access to getting to the hospital, is the idea that I think of more as how poverty interacts with biology in childhood cancer. And what do I mean by that? Two different things. So one, we know that poor children in the United States in general have inferior health as compared to non-poor children, having nothing to do with cancer. So they have more comorbid illnesses. For example, they might have asthma or diabetes. And might this inferior underlying health in the context of childhood cancer therapy put them at greater risk of toxicities of chemotherapy? And if you're having greater toxicity from your chemotherapy, is that something that might be driving some of the outcome disparities we see? Again, an active area of investigation for us. And kind of a final area of investigation from a biology perspective is understanding whether or not coming from a poor environment or a poor family might in fact impact whether your cancer is more drug resistant than some other cancers. And this is really building on work from general pediatrics that's trying to understand how exposure to stress and chronic upregulation of the stress system might actually impact the body long term. Again, an active area of investigation. So that was a long-winded way of saying we don't